So again, good evening. My name is Christopher White. I'm a staff at the University of Oklahoma, and I'm the shoulder and elbow surgeon for the group. And I was kindly asked to talk about arthroscopy of the post-traumatic elbow. And I know it's a brief talk, so I'll try to be as terse as I can. I do have a disclosure. You can see my face obviously on the Zoom, but this is the picture that's been circulated for me for about 15 years. And in pure disclosure, I'm no longer the 35-year-old, clean-shaven, relatively fit young man. I'm now a grizzly old man, and this is a more accurate representation of myself. In all fairness, I have no disclosures about relative to any sort of industry relative to this talk. Just a brief introduction for myself. I'm an Oklahoma native. For those not familiar with where Oklahoma is, it's in the center of the United States, and we like to consider ourselves the heartland or the crossroads of America. I went to the University of Oklahoma for my medical school, although this nice building wasn't there when I trained back in the early 90s to mid 90s. I had the fortune of being able to do my residency at the Mayo Clinic, and I had my fellowship was with Mr. Bell in Melbourne at the Shoulder and Elbow Center in Victoria, Australia, the beautiful town of Melbourne. So just to get a sense, not that it's important, but just to know where I'm coming from and perhaps what my bias in training might be. Just briefly about elbow arthroscopy, it's become a much more common procedure since the late 1990s. The initial indications, like they were for all forms of arthroscopy in different joints, were limited initially. And in the elbow, limited predominantly to synovectomies of rheumatoid elbows or perhaps hemophilic affected elbows, removal of loose bodies, and some diagnostic applications. And of course, the concerns then and now are, of course, the proximity of the neurologic and vascular structures to the elbow and their potential dangers or risk for injury during arthroscopy. However, over the last 2 decades, significant improvements have been made in techniques, and we're much more comfortable about scoping elbows. And these techniques have improved our safety and expanded our indications quite greatly. Just a few of these improvements, of course, are refining safe portal placement, the use of retractors intraoperatively, better preoperative imaging, so we understand the anatomy more, particularly more complex procedures, such as mapping nerves, perhaps, that have been transposed with ultrasound, 3D reconstructions, and even 3D printing some deformities that we want to better understand and treat arthroscopically. So our current elbow indications, this by no means is an exhausted list, but obviously we continue to do synovectomies, contracture releases, the so-called osteocapsular arthroplasty, the osteophyte removals, fracture fixation, arthroscopic assisted or arthroscopically guided. Actually, while I was putting this talk together, I got a ViewMedi email with another demonstration of coronoid fixation using arthroscopy for guidance. Treatment of osteochondral lesions, such as debridements and microfracture, and even some cartilage restoration type procedures. Treatment of instability, tumor treatments such as excision of osteoid osteomas, and synovial chondromatosis and other forms of tumors, and treatment of lateral elbow tendinopathy with debridements and repair, even excision of heterotopic ossification, hardware removal, and others. So what role does arthroscopy have in the treatment of the post-traumatic elbow? Well, if we think about the common sequela of trauma, the most common sequela of elbow trauma is stiffness, and then other sequelae include arthritis, hardware issues, persistent instability, heterotopic ossification, non-unions, malunions, and there are others like avascular necrosis, of course, but can arthroscopy help us with these common problems that we see after trauma in the elbow? And certainly for stiffness, this is the prime indication for arthroscopic intervention. Can we address arthritis with osteocapsular arthroplasties, with osteophyte debridement and removal of loose body synovectomy? Of course, that's a commonly accepted procedure? Can we remove hardware and perform some treatment for hardware issues? Yes. Can we address some persistent instability? In some cases, yes. Can we excise heterotopic ossification? In many cases, yes, but in some cases, no. Can we address non-unions? Well, in some cases we can. I've performed a radial head resection and a radial neck non-union that was symptomatic, and you can do those sort of things arthroscopically, but there's limited application, but there are certain situations where that could be useful. Malunions, in certain situations, arthroscopy perhaps has a role. So what are some contraindications for arthroscopy of the post-traumatic elbow? Well, clearly, if you have an ankylosed or non-existent joint, that's a pretty clear contraindication. If you're going to be doing surgery for extensive hardware requiring removal, that's a relative contraindication. Some complex radial ulnar disease, such as radial ulnar stenostosis, heterotopic ossification that the CT scan shows can't be safely separated from major nerves or vessels, ossification of the collateral ligaments that require resection and a subsequent reconstruction. Obviously, that's not something easily done or performed arthroscopically. Some relative contraindications, extra-articular heterotopic ossification. Some authors would say severe flexion limitations of greater than 90 degrees. Again, there's obviously many folks that will do arthroscopy in those situations, but some authors aren't particularly prone to do that. Some prior ulnar nerve surgery may be a relative contraindication for elbow arthroscopy, and then severe end-stage arthritis or joint disease that's beyond arthroscopic help, if you will. So just basic setup and techniques. I would encourage anyone who has interest or is not as familiar with this. Dr. O'Driscoll has a great article in JBJS in 2013, has associated videos and such. Very nice article that is one typical setup in treatment technique for arthroscopic intervention. The setup in the OR, there's various described setups, of course, for elbow arthroscopy, being supine, supine retraction, even prone. But my preferred setup in the operating room is a lateral decubitus position with an arm on a limb positioner, typically a non-sterile tourniquet inflated to about 250 millimeters of mercury. In some cases, if there's going to be an arthroscopy combined with an open procedure, perhaps a sterile tourniquet might be necessary if the extension needs to be extended or working beyond what a non-sterile tourniquet can give you. Meticulous fluid management is quite important in elbow arthroscopy. I prefer gravity. I know Dr. O'Driscoll talks about his putt-putt system, which is a 3-liter jet lavage system. I don't know of anyone else that really uses that, but perhaps others do, and I'm just unaware. Careful use of suction as to not draw in any of the neurovascular structures into the elbow. And some authors are proponents of not using suction at all, putting your outflow cannula or your outflow from your shaver to gravity. I use suction, but just use it carefully and with a light suction. And typically, elbow arthroscopy is performed with a large joint arthroscope, typically in the range of about 4 to 4.5 millimeters in diameter, depending upon your manufacturer. Certainly, small joint arthroscopes can be used, but typically a standard large joint arthroscope is certainly fine. Some commonly used portals for elbow arthroscopy, and one thing that's particularly reviewing for this talk, but obviously very commonly out there in the literature. Sorry about that. Is that these portals are named various names depending on the authors in the articles and textbooks or whatever you read. But in general, I'm trying to use the most common names for the portals that I use and are most commonly described, and that would be in the anterior compartment using an anterolateral portal, a proximal anterolateral portal, a proximal anteromedial portal, and then the posterior compartment using a posterior central or a direct posterior portal, a posterior lateral portal, and a direct or soft spot portal for visualization and instrumentation. There obviously are more portals described in accessory portals that can be used for instrumentation and for retraction. This is from Dr. O'Driscoll's article, just a stepwise approach to actually performing the procedure. He outlines it in step 1, get in and establish a view. Step 2, create a space in which to work, to safely visualize your instruments. Step 3, to perform the boning removal, such as removal of osteophytes or prominent malunited bone or removal of loose bodies. And the final step being the capsular work, such as a capsulectomy. Once you remove the capsule, obviously that increases your extravasation into the soft tissue. So how effective can elbow arthroscopy be for these sorts of procedures? So if we look at what the reported outcomes are, this is an article from the Journal of Shoulder and Elbow Surgery 2018, a review of 54 consecutive patients with extrinsic elbow contractures, with 31 being traumatic and 23 being degenerative. And both groups showed significant improvement in range of motion in the male elbow performance score with a minimal follow-up of 2 years. And the results were comparable for both traumatic and degenerative groups with no significant differences at final follow-up. And their conclusion was that arthroscopic arthrolysis is as effective for both traumatic and degenerative conditions. One thing that's kind of interesting about this, and a little pearl from this paper, is that, and we all see this in our own patients, is that our best range of motion is the range of motion we were able to obtain intraoperatively. What's interesting is, though everyone takes a hit initially, that flexion typically returns back to, close to your intraoperative findings, but extension never quite recovers. And that certainly mirrors my own personal experience. And there's very rare cases in which you gain range of motion more than you had at the time of the surgery, at the conclusion of the procedure. Another article, sorry. Another article that discusses the effectiveness of arthroscopy in traumatic situations is another article from 2018, reviewing 42 patients with elbow arthroscopy for traumatic and degenerative conditions. Both groups gained clinically significant improvement in their outcome and range of motion with a complication rate of about 12%, and no difference between the groups that were treated for either traumatic or degenerative conditions. And their conclusion was arthroscopic arthrolysis is an effective treatment for patients with restricted elbow range of motion for both post-traumatic and degenerative etiologies. And so how comparable is this to open surgery? So if we say this is an effective means by which to treat traumatic issues, particularly elbow stiffness, is this comparable to open procedures? And there are certainly articles that have reviewed this. This is a 2019 article looking at 44 cases where 13 were arthroscopic interventions and 31 were open procedures performing an osteocapsular arthroplasty for post-traumatic stiffness. Now, in all fairness, typically the arthroscopic patients had less loss of motion and other issues prior to the procedure, but their range of motion, male elbow performance score, and the visual analog score all improved significantly from preoperative values. The results were inferior with those with intra-articular fractures compared to extra-articular injuries, and that's pretty, or likely fairly self-intuitive. And their conclusion, though, was that arthroscopic osteocapsular arthroplasty is comparable to the corresponding open procedure. One thing that's interesting about this article is it points out that there is greater flexion in the arthroscopic group at the conclusion of their care or at their final follow-up, but actually, and that's statistically significant, but the amount of improvement was not any difference, and that's because the patients that had elbow arthroscopy had less lack of flexion than those that were treated with an open procedure. It's another article looking at surgical treatment of post-traumatic elbow stiffness, systematic review from 2013, looking at open and arthroscopic intervention and comparing these. There was, this is the, I want to caution everyone, the level of evidence in all of these studies, even the ones I quoted earlier, aren't, they're not a high level of evidence. And in their group, they had no level 1 or level 2 studies. and they didn't think that the evidence was conclusive enough for a definitive statistical conclusion. But they did note that the mean complication rate was less in the arthroscopic group and recommended that the least invasive method to accomplish your goals for treatment of the post-traumatic elbow should be used. And again, in all fairness, the arthroscopic procedures were often skewed to patients with less severe disease. So likely perhaps why the complication rates were lower. So if we say it's comparable to open procedures, well, how safe is it overall? And this is a recent article out of the Mayo Clinic from 2020, which was a retrospective review of elbow heterotopic ossification removal cases performed by a single surgeon over a period of from 1997 to 2014, comparing complications between arthroscopic groups with combined arthroscopy and open procedures and open procedures alone. And they had a total of 50 major complications in 46 cases, with 15% being in the arthroscopic group, 23% in the open group, and 17% in the combined group. They initiated some preventative measures about halfway through this time period to reduce some of the more major and common complications, such as hematomas requiring additional surgery and delayed onset ulnar neuritis, by prophylactic mini-open ulnar decompressions, and they reduced the major complications from 35% to 10% overall. And their conclusion was that the use of arthroscopy or a combined arthroscopic and open technique to remove heterotopic ossification around the elbow does not increase the risk of major complications. So in conclusion, the elbow arthroscopy has an evolving role in the treatment of post-traumatic elbow. I think that's fairly clear. The indications for elbow arthroscopy of the post-traumatic elbow are growing as our skill and experience grows with using the arthroscope within the elbow. Standard techniques for these arthroscopic skills and procedures are well established and are published in the literature. And studies indicate that it seems to be effective, relatively comparable to open techniques in experienced hands, and appears to be as safe as open techniques as well. So I just wanted to say thank you.